Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Ashley Leak Bryant, Associate Professor at the School of Nursing at the University of North Carolina, Lineberger Comprehensive Cancer Center. She will be discussing acute myeloid leukemia and management approaches for patients unfit for intensive chemotherapy with a focus on the nursing perspective. This episode is part of a larger educational program titled MidTalk 2021. Nurses discuss current and emerging management strategies in AML. For more information on Dr. Bryant, along with a link to the complete program, including a downloadable PDF covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what Dr. Bryant has to say.
So what is AML? AML is an aggressive blood cancer. It needs emergent care. So we need to treat patients urgently because oftentimes they're coming in with symptoms in which it causes them to feel very fatigued and oftentimes may even need an ICU visit. The median age is 68 years of age. It affects males more than females. And we also know that with AML that they have a high symptom burden and oftentimes they have functional decline. This is an AML treatment overview. We have the patient and the disease characteristics divided into not eligible for intensive therapy and eligible for intensive therapy. We're going to focus on HMA and VEN, or low-dose Ara-C and VEN, or low-dose Ara-C and GLAS. It's projected that about 20,000 new cases and about 11,400 deaths will occur in the U.S. this year. And biologically, we know that AML is very diverse, and there's various different karyotypes, mutations, and antigens. And we know that this number continues to increase over time based on the number of baby boomers who are living older. What's a typical clinical presentation for someone with AML? We often know that they come in with fatigue and tired, short of breath. They may have an infection that's reoccurring, and they may even have a low-grade or high-grade fever. They oftentimes may also have bleeding gums, a bleeding nose. They may have bruising over their body. And they may even have some ocular effects, and that may be related to leukostasis. They're presenting to us, and then we determine, is this a fit or unfit patient? And should we really think about low-intensive therapies or high-intensive therapies? If this person is a fit adult, that means they would be eligible for intensive induction chemotherapy. And this is based on favorable cytogenetics, favorable performance status, and favorable physical function. So that means they're able to do majority of their ADLs on their own without any assistance. We consider someone who's unfit as someone who's not eligible for intensive chemotherapy because their cytogenetics are abnormal, related to some type of deletion or translocation, rearrangement, duplication, and that means it's going to be harder for us really to treat them. And they have a higher number of comorbidities. And we all have seen these patients come into our clinics and to the hospital. So unfit AML patients, there are clinical challenges that we have to address with these patients. What is the AML treatment goal for them? As Dr. Tinsley mentioned, the ongoing discussions with patients are critically important as we think about quality of life. Are we trying to maintain their count versus improve their counts? Do they want to be transfusion independent or dependent? How do we minimize and manage these ongoing toxicities that we know will happen related to myelosuppression and from the side effects of the chemotherapy? We also think it's important to really think about what's quality of life to them and how do we ensure that they are getting those needs met? How do we restore their function that oftentimes may be deconditioned over time based on lying in bed for a certain period of time? And then are we really thinking about stabilizing their disease or curing their disease? And that's why we have to have this really focus on shared decision-making with the patient to ensure that their needs are being met. So what are some of the therapeutic options in AML based on fitness or physical function and cytogenetic factors? We have low-dose or non-intensive therapy for older adults with AML. So we know with chemotherapy that the cure rate is fairly low, less than 15% in those who are greater than 60 years of age. We know median survival is less than a year, so 6 to 10 months. And we know that the options are fairly limited. We have low-dose Ara-C, hypomethylating agents such as azacitidine, decitabine. And then we also have our targeted agents, venetoclax plus HMA, which we know is superior to venetoclax plus low-dose Ara-C. So venetoclax, it's a BCL2 inhibitor. It is an actual pill that people take, and it's given with low-dose cytarabine or with azacitidine to treat adults with newly diagnosed AML. These people are usually 75 years of age or older, or patients with comorbidities that prevent the use of standard intensive induction therapy. And we've seen patients as young as 55 or 60 on this medication. So for the VIALE-A trial, the AZA and VEN trial for naive AML and eligible for standard induction therapy, as you can see, patients who received AZA and VEN had better overall median survival. And so the hazard ratio is 0.66. So that means their likelihood of mortality was decreased. What about the safety of this trial? Oftentimes, these patients have bleeding, fevers, low red blood cells, and then there's the non-hematological, oftentimes the GI symptoms, followed by the infections, which we often think of pneumonia, and then there are serious adverse effects as well. So safety, we know, is very important for any kind of chemotherapy, but particularly for someone who's getting azacitidine and venetoclax. We also have the trial with low-dose Ara-C plus VEN. What we have here is pre-planned overall survival analysis, a follow-up at 12 months, and then we have an overall survival analysis with 6 months additional. So what's the takeaway message here? Takeaway message here is VEN plus low-dose Ara-C, you get 7.2 months, and then VEN plus Ara-C here for additional 6 months, 8.4 additional months. So there's benefits to having the venetoclax plus an HMA. What about the dosing of venetoclax? Definitely is something that may be different for each institution, but overall, day 1 doses of venetoclax, 100 milligrams, day 2 is 200 milligrams, and day 3 is 400 milligrams. If you're receiving the HMA component, you treat until the disease progression or unacceptable toxicity. We always encourage patients and their families to make sure that they're taking the venetoclax with food and water at approximately the same time of day. And that includes swallowing whole, do not crush in or break in first. And it's important to assess the individual patient for tumor lysis syndrome as well. Tumor lysis syndrome, the goal is to prevent and assess this really at each encounter. Our goal is patients should have their white count checked and assessed prior to initiation of venetoclax. So it needs to be less than 25,000. We also know that it's important to make sure that they have prophylactic hydration and any kind of medications on board, such as allopurinol, to reduce the risk of tumor lysis syndrome. And even through the ramp-up phase, we want to check their chemistries as well to ensure that we correct those prior to initiation of treatment with venetoclax, monitoring their blood chemistries often, and ensuring that any additional measures that increase laboratory monitoring is important. And really close monitoring of the venetoclax dosage is key. Tumor lysis syndrome, these are the labs we're most interested in. So uric acid, potassium, phosphorus, calcium, and creatinine. We consider someone in tumor lysis syndrome when they have these elevated levels, and then they have a decreased calcium level. So some drug interactions and dose adjustments for venetoclax. These are the different agents, and then the venetoclax dose modification. Oftentimes you're reducing by either 50% or 75%, or switching to an alternative agent. What are some of the nursing implications? So some common adverse effects of AML and the treatment is related to GI toxicities, as we've mentioned before. So nausea, vomiting, just upset stomach, myelosuppression. And we know fatigue is a common symptom for all cancer patients, but particularly for someone with AML or MDS. So how do we manage the GI toxicities? Really with medications, small meals, and the goal is for them to take their medication at least 30 minutes to an hour before eating. Try to reduce the amount of spicy foods as well that someone may be consuming. Myelosuppression, we know will occur. And so thinking about neutropenia, so lots of great hand hygiene, staying away from people who are sick, wearing the mask, trying to really manage the anemia, which oftentimes we know that people feel better once they receive some red blood cells. And then thrombocytopenia, and we think of safety with the risk of bleeding. So ensuring that you're not getting any extra sticks and you're not really engaged in any vigorous activities. Fatigue, common problem in patients with cancer. And so working with both the patient and the family to identify and improve fatigue. and clustering the care and the activities throughout the day. We do know that physical activity has been established as the most effective way to manage fatigue. When we say physical activity, it could be just walking outside, potentially to the mailbox if it's fairly close, just where you're able to move your body. And then discuss the impact that fatigue has on daily activities and social activities, because we know that oftentimes older adults aren't able to enjoy those things as they had before based on their limitations because of the fatigue. We also know with venetoclax, there is concern about oral adherence. And so there's a study that my colleagues and I conducted with adults with AML, and we found that there were three main themes related to venetoclax. Medication adherence challenges, how can someone manage an oral adherence plan, and how can we improve oral adherence? And participants recommended the following: that written schedules were very helpful for them, taking medications around meals, and using some kind of pill box or reminders, such as alarms, are helpful. So here are the common challenges that patients faced. This was a mixed method study with 3 different sites. We collected data on 100 patients with AML, and we found that common challenges were number of pills that patients are taking. So in addition to taking their venetoclax, they're taking also their other medications for their comorbidities. Adverse events, we know that loss of appetite was common, and so that was probably a most problematic adverse event. And so more than likely, they would be less likely to take their medication, or they're going to pick and choose which medication to choose to take for that day. What worked best for the oral adherence plan was making it a part of the daily routine, thinking about the morning routine, if they're sitting down to watch a TV show or they have a phone call every day around the same time, if they make it part of their daily routine, that was key. And the best source of information was from the healthcare team. So in summary, we know it's important to manage both physical and psychological symptoms of these patients, that there are different barriers and challenges that patients face, but it's important to make sure that we assess those barriers to transportation or finances that may limit their ability to come back and forth to the clinic or hospital for follow-up visits. And the focus of interdisciplinary collaboration is critically important as we work with pharmacists, social workers, and others to ensure that the patient's needs are being met.
Thank you very much, Dr. Bryant, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, NED Talk 2021, Nurses Discuss Current and Emerging Management Strategies in AML, and to download the associated PDF from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.